If you are preparing for the MRCP and don't have hours to study every day, this channel is for you. Daily MRCP questions every day. You will watch just 2 videos with around 10 MCQ questions. It won't take more than 10 minutes of your time. Let's do the math together. 10 questions a day for 30 days. That's about 300 questions every month. No pressure, no long study sessions, just 2 videos a day. Answer in the comments, listen to the explanation and revise quickly. If you want to study smart and make MRCP a part of your daily routine, subscribe to the channel. Here are 5 MRCP MCQs to test your knowledge. Try to comment your answers below. Let's start with question 1. A 50-year-old woman has been admitted to the hospital and the renal team over concerns about possible lupus nephritis after recent blood tests showed acute kidney injury. Her past medical history include systemic lupus erythematosus, 2 prior transient ischemic attacks, hypertension, and obesity. She takes hydroxychloroquine, clopidogrel, and ramipril regularly. Ultrasound revealed right renal pelvis appears dilated, raising concerns for hydronephrosis. There is no visible obstruction. Both kidneys appears atrophic. The renal team is planning to perform a renal biopsy to look for evidence of lupus nephritis. What's an absolute contraindication to the procedure? A. Hydronephrosis. B. Antiplatelet therapy. C. Renal atrophy. D. Hypertension. Can you answer this? Comment below. The correct answer is A. Hydronephrosis. Let's revise together. The absolute contraindication to renal biopsy are 1. Hydronephrosis, 2. Obstruction of the renal tract, 3. Presence of polycystic disease. But renal atrophy, hypertension, and antiplatelet therapy all are a relative contraindication to renal biopsy. Question 2. An 19-year-old male presented with facial puffiness and leg swelling over the past few days. He had no past medical history and he took no regular medications. On examination, his blood pressure was 140 over 80 mm mercury. Pulse was 85 beats per minute. Urine analysis showed protein 4+ and blood 1+, but was negative for glucose. Lab result shows CBC was normal, sodium 144 millimole per liter, potassium 4 millimole per liter, urea 5.5 millimole per liter, creatinine 78 micromole per liter, serum albumin 20 gram per liter, 24-hour urinary proteins 5.1 gram. Renal biopsy showed podocyte fusion on electron microscope. What is the most appropriate next step in treatment? A. IVIG. B. Prednisolone. C. Plasmapheresis. D. Ramipril. Please pause the video and comment with the answer. The correct answer is B. Prednisolone. Why? Because the commonest cause of nephrotic syndrome in young patients, as in this case, is minimal change disease. This is supported by the characteristic histological appearance of podocyte fusion. The management of minimal change disease include prednisolone in the first instance. Question 3. A 40-year-old lady was admitted feeling generally unwell with a generalized aches, headache, and fever. She had a previous medical history of type 1 diabetes and end-stage renal failure. She had undergone a simultaneous pancreas kidney transplant 10 months prior to admission with good graft function. 4 months previously, she had been admitted with neutropenia, which had led to early cessation of her valganciclovir, and a reduction in her immune suppression. Her medications comprised of tacrolimus, prednisolone, mycophenolate, and aspirin. On examination, she appeared pale and unwell. She had a midline laparotomy scar with a palpable renal transplant in the left iliac fossa. Her temperature was 39.4 degrees Celsius. Her pulse was 115 beats per minute and regular. Her blood pressure was 100/60 mm mercury. Respiratory rate 22 breaths per minute. Oxygen saturation 95% on room air. Investigation: hemoglobin 108 gram per liter, white count 9,000, platelets 347, neutrophil count 7.6, lymphocyte count 0.5, sodium 129, potassium 5.4, urea 7.4, albumin 32 gram per liter, alkaline phosphatase 200, ALT 46, CRP 100, chest X-ray clear lung fields. What is the most likely diagnosis? A. BK virus infection, B. hepatitis C infection, C. CMV infection, D. upper respiratory tract infection. Please pause the video and comment with the answer. The correct answer is CMV infection. Why? This lady was presented with the classical symptoms of CMV infection. CMV infection normally presents 1 to 4 months after renal transplantation or stopping CMV prophylaxis, Valgan cyclovir, as in this case. Question 4. A 50-year-old lady presented with pain radiating from her right loin to her right groin. Past medical history, recurrent TI, and is on prophylactic nitrofurantoin. Observations: heart rate 100 beats per minute, blood pressure 125/70 mm mercury, respiratory rate 18 breaths per minute, oxygen saturation 96% on room air, temperature 37 degrees Celsius. On examination, the patient is restless and in pain. Urine analysis showed blood 3+, protein negative, leukocyte 1+, glucose negative, pH 8.4. Given the likely diagnosis, what is the likely composition of causative pathology? A. Uric acid, B. Calcium oxalate, C. Calcium phosphate, D. struvite. Please pause the video and comment with the answer. The correct answer is D. Struvite. Why? Because struvite stones are formed in the presence of increased urinary ammonia and alkaline urine. Question 5. A 50-year-old male present acutely as a primary percutaneous coronary intervention call after a sudden onset of chest pain 3 hours ago. ECG revealed ST elevation on V2, V5, past medical history, hypertension, type 2 diabetes mellitus, CKD, creatinine baseline 170 micromole per liter. He undergoes angioplasty and a single eluting stent to his left anterior descending artery. On examination, he is pain-free, warm peripherally without respiratory distress. Capillary refill time is less than 2 seconds. Jugular venous pulse at 3 cm above the angle of Lewis. Echocardiography after procedure demonstrate moderate left ventricular impairment with no valve abnormalities. At 24 hours after admission, his blood tests are repeated and are as follows. Hemoglobin 92 gram per liter, white count 13 per liter, platelets 198, sodium 138, potassium 4.2, urea 12, creatinine 254 micromole per liter, troponin elevated. What is the most appropriate next management step in addition to optimization of hydration status? A. Monitor with daily urea and electrolytes. B. Hemofiltration. C. IV mannitol. D. Organize urgent hemodialysis. Please pause the video and comment with the answer below. The correct answer is A. Monitor with daily urea and electrolytes. Why? Because AKI following a PCI most probably due to contrast-induced nephropathy. In this case, there is no indication for acute replacement therapy. At the end of our video for today, how many did you get right? Comment below and subscribe for daily MRCP MCQs. Thank you.